Thank you for everybody. Thank you, Katie. Thank you for people for joining. This is going to be starting in just a bit, but we're going to have a conversation with Dr. Michael Wolf from Northwestern University, and it'd be great if people would feel free to post questions either in the chat or Q&A. You may or may not appreciate Michael's use of what's that guy's name again?
Mike Myers.
Mike Myers.
But I'll switch back to purple. It balances off of the bright colors in your Zoom.
Oh, I can be sure to change that too. Maybe that's not right.
Yeah.
This is for you, Mike.
There we go. Thank you, Chicago. Appreciate the ode to Chicago.
Yes, there you go. Great. So I think we can get started, but it would have been nice if we had thought to set this up as a group room, but unfortunately, it's set up without people being able to unmute themselves. So please, as questions come up for folks, if you would type them in, we'll try to do our best to pay attention to the chat. It's kind of an opportunity to hear from Mike. Mike, you are in fact, I believe you are in fact the most published, most cited health literacy investigator in the world. Do you accept this? Is that true?
I don't know how you rate that, so I'll pass on that. And I'm not sure who the couple is behind you, by the way. But
oh, that's Sarah and my kid Lev.
Oh, that's fantastic. So yeah, you're hiding him. But I think there's I don't think that's a metric that's probably worth that much, since quantity over quality might not be the best way to judge.
Well,
our question's been really
well. Someone actually wrote a paper about this, Mike.
the +1 paper, yes. Stacy pointed it out to me.
There's a paper. You're rated number 1. I think I'm rated number 3.
Well, I know it was a God, honestly, if people hasn't seen, it's like a +1 paper, and I'm not really sure the point of the paper. They had some really interesting visuals, but I didn't know at the end of the day what they were trying to get at, other than maybe a few of us were being opportunistic in the early 2000s to get health literacy off the ground.
Well, I think that group basically, they wrote like 15 or 20 papers with basically doing that same paper again, but applying it to different fields.
Different fields.
Yeah, they had like they submitted them all around to different journals, and we got health literacy got delegated to +1.
That's a great tier journal. So I was like kind of surprised that it made it in there. So that was pretty funny. So yeah. But okay. I think we both are a little bit gray in terms of having been doing this for a long time. So I view this as more of a dialogue between us in terms of talking about where we've been, where we are, and where we're hoping to go.
Yes, I think that's what's going to happen. But you're now the third person today to point out how gray I've gotten. So I don't know. No, I think it's true. It's the honest. It's honest. This field has evolved some in different ways, and I hope we get to talk about this over the course of this session. I see some names here in attendance of participants here of people who have also been, really doing great work over the years in health literacy, and also some new names, which is fantastic too. And so if this is an old space for you or a new space for you, either way, it'd be great if you could put your comments or questions into the chat. And why don't we kick it off? So, Mike, where has this field been? Where is it now? Where does it need to go? Let's start to take this on.
Yeah, sure. I
Yeah.
mean, just sure. Yeah. Yeah, there's been, I feel like we're kind of maybe a second generation to the first two, that really kind of labeled, health literacy in a more formal way back in like the late 90s, even though it's been kind of tossed around. And since I think the 70s, the term health literacy was kind of being used, but it didn't really get traction until a lot of the people who mentored you and I really fought for it, and then got AMA backing and then industry backing to kind of lead to NIH's getting a pretty large amount of attention with a pretty huge investment starting, I think, in 2004. And I think a lot of that was us. We really focused around this idea of people who couldn't read well, which evolved to people who may just have, general lack of health knowledge, to I think what we've studied at Northwestern and amongst others too, thinking that maybe there's more of a global skill set or set of healthcare competencies that we weren't really passing on well to consumers of healthcare services and products that we were trying to draw attention to. I feel like there was always an element, at least among those of us kind of who were really interested in the field a lot, that it was not blaming the patient, but it was more about improving engagement with patients. And I feel that we've done a pretty good job there. But I feel like, and this is the thing, love to get your feedback, Michael, but we had so much traction, and this became such a big focus nationally and internationally when it became about pointing out the problems and showing in thousands of instances where people with limited health literacy had poor health knowledge in a specific disease or treatment, or inadequate health behaviors, or ultimately some level of clinical outcomes, or even mortality and hospitalization. And then when we flip the switch to like moving towards solutions and interventions, it kind of went scattershot a bit. And I think we've really struggled to figure out what health literacy is as a result, because I think it has a lot of definitions within it, and how we define what a health literacy intervention, I feel, has always been a bit diffuse. And then I feel like we lost a little bit of traction. Sometimes it's easier and more, I hate using this word for research, but more sexy to talk about a problem than it is to talk about what might work. We had some great wins with some kitchen sink type interventions that, when you throw everything at it, see what sticks on the wall, and then you realize that there's benefit, but you don't really know what caused it. I feel like we had a few of those. And then I feel like we reverted a bit back to where we were trying to get away from in the beginning. A lot of it focused on how people, engage with health information, when I think it could be much bigger. And especially with emerging technologies and the role of patient changing and how we can access health information and healthcare services, what we learned from COVID. I feel like there's just a ton of things that are ripe for health literacy to kind of be re-engaged in, and to really be a force. And even we should be very proud about where Healthy People 2030 health literacy is very prominently highlighted there, but maybe in a way that still needs a bit more being more operationalized as to what we could be doing with it. So I don't know, I just throwing it back to you, the same question, how you perceive the past few years, or the past decade.
Well, no, I think you're absolutely right. I mean, and a transition's happening. From the prescription to end confusion time, several key people from that effort have retired or are retiring now, and not everybody, but several of the key players. And just for a shameless plug, for those who didn't already hear me say it, we have a special issue for the journal Health Literacy Research and Practice that we're currently working on, and submissions we're still taking submissions in honor of Rima Rudd, because in honor of her retirement and her efforts through the years. Just, there are several of the key people who were in the generation just before us, Mike, who carried the torch and really moved the field along. But so much of what we were imagining about in 2004 has evolved, and yet so much hasn't changed as well. There was this period in between that you alluded to with NIH funding, where there was really with the report, and then afterwards with the funding. When there was when there was a centralized program announcement at NIH, we kind of had a real force, with the HHS working group, and many of them were connected to a common funding mechanism. Then we had a sense that we could, as a group, we could say, this is what the field is, and this is what's happening in this space. Now it's kind of all over. So you mentioned scattershot. So most of the institutes are doing their own thing or not. It's hard to even follow what is and what isn't health literacy per se. Yeah, I think in many ways it's gotten stale, and we have to reinvigorate here. This is the 15th year of HARC.
Yeah, wow.
Before HARC, you'll remember it was the Pfizer Clear Health Communication meeting.
Yeah. Pfizer really helped kind of fill the void before we got the NIH funding, and they brought people together. I mean, it was a little bit different, right? Because it was about, if you went to the meetings, it was about 80% industry and 20% academics kind of floating about. But I think the fact that industry kind of really did kind of help catalyze what became NIH funding, working with the AMA and others, I think was a really great thing. And there's still a lot of opportunity since, to continue to work with industry, whether it be pharma or health insurance. I mean, we haven't solved that issue on people trying to figure out and navigate healthcare, which has just been a huge, continues to be a huge mess, but in need of attention. But so we shouldn't, but you're right, we need a B12 shot for health literacy to get reinvigorated about it. And some of it might be, I keep thinking about this, not to kind of say we always want to focus on the problem, but I think we need to remind people that there is inequities that are, driven by health literacy, and not having, and it's a modifiable factor, and there's a lot of value in, especially in the short term. I mean, we always struggle with how do you address, through, bigger picture issues around policy to get, really needed reductions in socioeconomic disparities. But there is something right at hand we could be doing. And I remember colleagues at Northwestern, one that presented yesterday, Stacey Bailey, asked me about 15 years ago, is this a field that's got traction? Basically, should I hitch myself to this wagon, or is this going to kind of dissipate? And my thought then was, and I still think it now, is I don't think our healthcare system is going to resolve all of the many issues it has anytime soon, and a lot of them are user interface. And even if you have to start picking apart, problem by problem with an assistant, and be that myopic, there's a lot of value in kind of doing that. And I think a lot of us have, focusing on something around patient education or reducing care complexity in a given kind of, continuum of services. It'd be nice if you could have a higher level perch to kind of look down and work with a healthcare system like Marion Abrams has, like what Cindy Brock has been doing for years with the Health Literacy Toolkit, and Darren DeWald and others who have been really instrumental in those activities. It's the implementation and the dissemination of those practices when you do find something that works in the space of health literacy that I think has also kind of floundered a bit. I don't feel like I know, maybe those of you on this session know, really, do we really have a good catalog of what has worked, what doesn't work, what really do we need more evidence about? I'd even pick on teach back. We love to talk about teach back, but the evidence is still pretty murky. If you think of real science around whether that works, it's also really tough to implement, especially when you've got clinicians thinking, is this going to take me another 3 to 5 minutes to do? I mean, there's just some very real world things about understanding, that might also help us understand what we are and what we do, and project that out to other people who are not in the field and understanding the value proposition of a health literacy lens, as Ruth Parker likes to refer to it as.
Yeah. So, Mike, there's several different questions that were posed, and I'm gonna just interject them as we go along. But one of them really is this in Healthy People 2030, that now we have this kind of 2 definition business. And like you said already, like from the beginning, it was already understood that, that it was health literacy skills, but in a context. And of course, it'd be like blaming the victim to just point to the patient if like the providers are talking in jargon all the time. And, but now more formally, there's with these 2 different definitions with organizational health literacy and individual health literacy. How do you see this? Does this change the landscape, or does this make it, what's going to be the impact of this? What do you think?
I don't think it has that much impact. I think I mean, again, because I think a lot of us were thinking of it that way in terms of like, this is not about the responsibility of the patient to do better, and be more attentive and to go, read up on their healthcare, or providing some sort of user manual for a fairly complex healthcare system. I think we could be better operationalizing that. I don't think the definition goes far enough in really helping, or at least we need to help operationally definition of what does it mean to have organizational health literacy? What does it look like on the ground level? To my understanding, I don't know, many of us, again, our mentors in particular were instrumental with like Joint Commission and NCQA kind of things, like in thinking about how does health literacy fit in? Like, how would you walk in and into a health system that you're evaluating in terms of quality and meeting quality indicators and metrics? And how would you put a health literacy, how are they doing? Are they a healthcare organization? I mean, those types of groups that could help us understand how we actually measure and define that, yes, you have succeeded in implementing things that we think would be good from an organizational health literacy perspective. I think those things are needed. And I guess I'm a little bit out, but in one of obviously our mentors, David Baker, who's now, he heads measurement, quality and measurement for the Joint Commission. It's like, how do we get that attention to be paid in those spaces? But that I think would have more of a, yeah, go ahead.
No, a couple of things on this, because you mentioned Dave, and so there are ways in which the field has really succeeded. It happens, now and again, actually not even so infrequently, that I'll be someplace in a hospital, someplace, and an intern, not knowing who I am or what I do, will mention health literacy as an issue for a patient.
Yeah.
So this has actually, the problem has like people have a broader notion of that there's this issue there. But then, how to actually have the impact of you mentioned the implementation issues. I completely agree. But when I've asked Dave about these things, like, could there be standards through, JACO and everything? Could there be measured, could there be, my sense of the answer is kind of like, well, we can't, can't go so much past where the organizations are that none of them would make the target. Like, they would all fail, like, if we established a standard for something that they just can't do, then they would all fail and they would revolt. And they, effectively as an accrediting body, they only can move the needle incrementally and slowly, and only on things like, that they know people will, on average, be able to do. And so they don't take on problems that are like harder for the institutions to do, then they'll succeed, or else they'll get in trouble that as an accrediting body asking them to do more than just like wash your hands. Now you can complain about that characterization, but that's my impression with why they haven't taken on like things like Teach Back.
Hmm. Yeah, I agree with you. I think like it's it comes back to me when for many years you were thinking about hospital assessments based on readmissions, and you've been very focused on and how do you deal with the fact that you know people are not all hospitals are not all equal in terms of the communities they serve, and the unfairness to some of the hospitals that are getting resources taken away from them that could be maybe mandated to be that this was your idea, right? Reproportion the money. So we want you to dedicate more work towards health literacy in your communities rather than to just take the money out altogether. And so I thought that was a brilliant thought, and that was at least a decade ago, right? That was Project Reddish time
Yeah,
frame. But I do think that I remember being and there's a comment in the chat about getting a National Academy of Medicine meeting. Hi, Claudia. It's nice to see your name again. You know, the, and I think that is an important point, but like, we have a health literacy working group that you and I both serve on, Michael. And I think it hasn't, I think that needs a bit of a reboot as well, probably in thinking about how do you really breathe life into this again and have it serve as a real good advocate broadly to get people's attention more. But I think that one of the things I remember being at a National Academy meeting and the term that some of the people in the academies did not like that I kept saying is I think we need to, there needs to be more discussion around ROI. You need to have health systems have to understand what is the return on investment, or industry for that matter, to understand how does this actually come back to me in terms of actually is there a way that this saves me money. And we talked to one very large healthcare organization slash industry organization that I won't name, but they were talking about unless you can tell me that this is going to help us sell more product, that's going to help us get in front of a mandate that we know is coming, so we might as well do it now anyway, or if it can help me with any safety concerns that we have, which would lead to litigation, and more importantly, if it helps me improve workflow efficiencies. And so like those are the things they said that those are the things that grab our attention. And if you can't show those things and it's just an investment where we can't see how that actually pays off, and what like for like a health organization that I work with in my own backyard with Northwestern, I think a lot of it would be, and if it also gives more credibility, or in the community it increases our value or perceived you know, um, status in the Chicagoland area, I think that would be another sell. But people didn't like that framing of ROI, and it seemed ugly to them when you're coming from a public health perspective. But quite honestly, that's how we need to engage them better. It's just that we need to show why this works.
yeah.
And so maybe reminding them of the detriment by not investing, by showing more, reminding them that the problem still is apparent. There's still disparities in health outcomes that exist. Maybe we need more of those studies again.
Yeah. Well, I think I would say that the nature of that conversation, even the definition of how you would even operationalize an ROI conversation would vary by the kinds of stakeholders, you're engaged with and how they're compensated.
Yeah.
So, as we shift from a fee-for-service environment to a population health environment, this may in fact be really, the methods for how you demonstrate the ROI is going to shift. The hospitals will shift from being paid with the beds full to, keeping people healthy and not having to be hospitalized, and it really shifts the conversation. I think health literacy actually goes more earlier into the conversation instead of just like the people who are the sickest getting all the resources. That you have to move it upstream and by a lot. I want to just bring up a couple of these additional questions. Greg is wondering, if NIH traction is waning and in our work with the national academies isn't as effective anymore. Do we need a national association to prioritize and drive this work?
Wow, that's I mean, it's a good question, because you're right, and you brought it up earlier, Michael, too, that like, where we used to have this great RFA with a dedicated special emphasis panel that would help us prioritize work, and we had a massive, again, if I don't know if Marion Allen is on this line, but man, a big shout out to her for being a big champion in that regard, as well as Cindy and Carolyn Clancy. But you know, it is disparate. It is, I mean, you're basically either, I mean, if you're not targeting, opioids or Alzheimer's, where so much money has been kind of appropriated, you are having to look program announcement by program announcement. There's no kind of corner of it. And even I would say a lot of NIH institutes that I previously signed on to the health literacy funding from 2004, I think it was, to 2014, or about a decade or so, good, solid, protected funding. Even HARC was one of the first ones, even while it was still active, to pull out. And that HARC has always been a huge champion, thanks to Cindy and Carolyn. And so the fact that now institutes are really doing less research that is more behavioral focused or health promotion focused, it's their pot is shrinking within some big institutes. That it would be nice if an association could do that. I think helping existing institutions that would be faster, maybe like an APHA, Academy Health, professional organizations that have more lobbying power, or maybe more direct influence, would be a faster route to do that. Helping them get signed on versus a National Association of Health Literacy. I think that probably takes a lot of time to, water and grow to get it to a point where it really could have some strengths. But I would defer that question to someone who is into the organization building field.
Well, yeah. So I mean, there's a lot of different pockets where these things are happening or not happening. We have some states have state associate, state networks, and there's some, some of us are involved in ILA, the International Health Literacy Association. There's just different ways that this is kind of playing out or not playing out. I think there are areas of research that will have, more chance of having approximate effects. Greg's pointing out, maybe we should, focus on things that could actually speed change by hitting them, where the money is. Yeah. So, but it's not so easy. And there's other research we have to do that's really even still formative. And I'm gonna turn this to a new topic soon, which is the lifespan issue that I want to get you to talk about, because this is something that you've done a lot of work in, and I think of it as still kind of on the more formative side in various ways. But before we get there, it is a little bit of a mystery what topics end up with a national organization around them and move forward and actually kind of create a, like, if you will, a movement around them, and others don't quite, so
what gels and doesn't gel.
yeah. So just to, I think that's the fact that this is the 15th year of HARC, and we have, in the range of, 200 to 300 people sign up for HARC every year. But it's not at this point, 10 times that much or 100 times that much. It means that as a field, we actually haven't, gotten to that. There hasn't been a chat bot that just magnified our impact online, or so, something. So we're continuing our work. We're doing good stuff. We're having the impact we have. We're entering into the culture. People say these words, but it hasn't exploded. And I don't know, if we even have the momentum right now to succeed with the national organization. My worry is that it wouldn't actually explode. So
I mean,
yeah.
Well, to your point, I think and I see some of the comments in the chat. I think if I've been a long time. I've missed the past couple years of the International Conference for Communication and Healthcare, which is the European and American Association Conference, and that one has, I feel like I've been going that one for probably about 20 years, and that has slowly and gradually grown. I think it's probably doubled in size in the 20 years that I've gone, and probably a lot of that's been on the European side.
Yeah, no, but I'm going to say that actually, is mostly an academic venue.
Yeah,
I've
yeah,
enjoyed their meetings too, but it's an academic. It's incredibly unclear if there's any impact. Um,
yeah, yeah. So if you're trying to build an organization that has more of a lobbying power, that is going to be more influential in getting attention to funding, yet ICCH or that may not be the best model. I think it's been a great bridge to direct in, where people are doing research. um, I was thinking from the one thing I was thinking, just you're right, locally it's still a small group, but it does have two associations that help, pool and support the venue, that brings people together. So yeah, as a research activity, like having a foundation, even if it's smaller, it's definitely smaller on the American side, might just help keep the research going a bit more. Again, that's where, I mean, you're right. I think like a health literacy specific organization, just to me, like if you're thinking of a 10-year plan, then maybe. If you're thinking about how do we inform things more immediately, again, I would probably try to find, an existing. I mean, I think what we did, I mean, like what started in 1998 with the JAMA publication that signed on to the health literacy work group that really just kind of pointed out this is a problem, was the AMA putting support behind it and doing the first video with Terry Davis, Luke Parker, and Mark Williams, and others. And I mean, I think that, and then of course industry kind of carried us through. I feel like you still have a lot of industry support, even if you look at the health literacy working group. But yeah, I don't know the best path forward in terms of trying to get NIH to put as much money into it, especially if they're looking at the billion or so dollars, or I think I can't remember what the exact amount. I presented it at HARC many years ago, right as it was closing up, but it was a huge amount. And if they're going to look back and say, why should we reinvest? What came out of what you did the first decade of funding, where you really did have projected funds? I don't know if we've done I don't know. I don't know, and maybe NIH has that report. Maren would know how they've summarized all that we've done. Was it worth it? I don't know.
Actually, I don't think NIH uses any metrics that I think are relevant in this regard. They actually are looking at publications and subsequent grants by their funded parties. They don't have metrics, as far as I can tell. I've talked with different people about it,
Corey.
on things like impact on society, or changes in quality or safety, like things that actually would be maybe around practice. They're not, it's just not connected. It happens actually frequently when I talk to people from other countries, when they see things like the AHRQ or toolkit. They're like, they assume that all hospitals in the United States abide by it. It's like, because
Yeah.
like we don't have such a system, and we don't have that power here in the US. It's kind of bizarre. Anyway, so there's some excellent comments in the chat that have come up. There is the IHLA, although it's unclear. It's also itself not exploded. I just don't think that the AAPM, what it used to be called, the communication, like, I like those meetings, but it's because I'm an academic. And if you went there and said, I want to see health systems change around these topics, I don't think you're going to see that.
But the comment by Greg in the Q&A about going direct, kind of going to the source, that's kind of what we've been doing with pharma for a long time, where they were fearing a mandate, or maybe not fearing, but looking across the the waters and to the EU and seeing that they did have a mandate to do more user testing and be mindful of literacy. And so I feel like regulatory affairs in pharma had a lot of attention to it, and we also had a lot of support and from, I think, a lot of healthcare payers too, like insurers. But go to EHR vendors, for us to go to like user conferences to give them feedback, especially as we start to see increases in healthcare access disparities as a result of telehealth coming out of patient portals, all the stuff that became more important during COVID. I think I mentioned to you, Michael, before, we have a Esther Yoon, to give her a shout out, as a doctoral student that just graduated in 2023. She has a paper pending right now where we did a study. We had a large cohort that we developed over COVID, where we had data on patients' telehealth use, portal use, just technology use from pre, peri, post pandemic, and disparities by age, by sex, by race, by comorbidity, that were very, very present in our cohort, in terms of using health telemedicine, use the ability to navigate a patient portal in a meaningful way. Those evaporated. The one that didn't evaporate, that actually gotten worse, was those among patients with limited health literacy. So, I mean, taking that information to an EHR vendor, I think that is an idea. We need to be present at. I mean, they do have access, where they do want to learn from their stakeholders, the people who have bought their billion-dollar epic platforms, to know how are we doing. And I think from a health literacy lens, we need to let them know this is the health literacy disparity is one that they should be attentive to. So I think it's a great idea.
Yeah, no, I think that's a very important observation to make about, a lot of the things we've been doing actually may, even if people have access to the technologies, I mean, there are more smartphones in the United States than there are people in the United States. And so the divide by access to technology has narrowed, like you said, but the health literacy divide has grown. And so, it's come up a few times today in various sessions. Victoria put it up again just now in the Q&A about AI. Like, who could we go to say we need safeguards on large language models and AI to protect people with low health literacy? Like, actually, I don't know who we should go to. I mean, we could go back to the roundtable, to the National Academy of Medicine, and actually we probably could even, get them to do a session on it, and we could actually make a report. We literally could instigate such a thing, and then we would write a report. And then would anything happen? So, because we've been through this now, like we've gone to that rodeo several times. Mike and I have been on various roundtable events. We've done reports, and like maybe something can come of it. Okay, so I had said I wanted to get you to talk about the lifespan stuff, but actually, when you mentioned pharma and getting them to actually get involved, it made me want to ask you something else first, which is, can you kind of review the path that you went through with the medication label and the medication setup, and as a story, kind of the arc of that for you, and where you see that going? And I think it's actually a good example where actually people can have an impact.
Okay. I didn't think you liked my bubble slides of Michael and I have been on so many panels for years about this, but yeah, I mean, so I think this is probably one of the when you're in academia, you have this chip on your shoulder that, you have to reset your expectations, right? So if you get a couple people who actually read that paper you wrote in a journal, you get excited, and then you realize, wow, life is really about, when the stakes are small, kind of thing. I mean, like, it's been great, but it does sometimes, you feel like you're kind of, shouting into a hole, like no one's really attentive to your work, or it's not having meaningful. But this was it was really cool. What happened was, what we call ourselves the three-legged stool: Terry Davis, Ruth Parker, and myself. The two of them were very, very huge mentors to me. I met Terry the very first day I started fellowship at Northwestern, and we've been close ever since. And Ruth, I met probably 6 months later. So, and the idea was, we started, again, back in the days when we were just picking apart problems, and we happened to have studies where we were trying to have people interact with common healthcare artifacts like a pill bottle, and started to realize that, wow, patients were making a lot of common mistakes on how they dosed out medication, and how they misinterpreted warnings or any other kind of special instructions on how they took medication. And we did a lot of papers on it. And I also credit Alistair Wood, who was at Vanderbilt, but then and served on and chaired many FDA panels. He is a pharmacologist and an amazing thinker. And the four of us started working on just kind of peeling apart, let's start to understand the full expanse of a root cause of a problem, on how people may unintentionally, and that's the key word, unintentionally misused medications, and how it's really from the confusing and dynamic nature of how medications are prescribed and how they're dispensed. We started unpacking like why are people getting all these weird instructions, and we started to look at variability in how doctors prescribe medications, how it was off the chart. We had a publication like 52 different ways to prescribe 52 different ways to say take one tablet a day. And then we looked at how pharmacies interpreted instructions and found that they even vary in how they transcribe medications. And so this led to us creating something. We said, well, I think this was where Alistair stepped in and said, can we just, God damn it, can we not just confuse patients less? And so we came up with this thing, following a medication pillbox organizer schema, which was the universal medication schedule, which was something as super simple as writing, having a way to standardize how doctors prescribe medications, any prescriber prescribes a medication, and how pharmacists interpret them and transcribe them. So at least people would have uniformity how they got the medicines. And could we be a bit more explicit? So wouldn't it be more health literate to say, take in the morning, or we had also previously pitched the national academies, which really helped launch us and get our research a lot of national attention through social media and through, I think we had NPR was waiting in the wings when we first presented this, and really launched a bunch of national headlines about this problem, about people might misuse a medication. And so the universal medication schedule really was saying take pills morning, noon, evening, bedtime. We avoided meal times because there was a lot of outcry during the national academies about that might be inappropriate for what I would say is the far fewer medications that are prescribed to be not taken with meals versus the other way around. But just because of that concern, we backed off. And then also we realized with machine learning, you could actually easily, if it was to be taken with bedtime or with dinner, you could say dinner instead of evening and so forth. So long story short, we pitched it, we proved research. We had 2 grants from HARC to show, to do trials to show that it actually improves over variable, usual care arm, that they do a better job of helping people understand and safely use their medications. We had a big study with Walgreens partnered, where we looked at around 790,000 prescriptions of new diabetes medications among all diabetic patients, and showed that prescriptions that were using UMS significantly improved adherence among patients with lower education, who are over 65 with more comorbidities. And then we got traction working with policymakers. And so the probably biggest one was in 2011, where the state of California, I can't believe I love saying that I actually have a document that shows my name mentioned in a bill signed by Arnold Schwarzenegger. That was kind of cool. But yeah, we got a bill, and then I think we've seen a lot of movement move forward. Some great work even in industry. There's a group with First Data Bank that has now implemented it. So I think that I hope it's not the last big win, but it was definitely a fun win to be a part of. And that, again, Alistair, Terry, Ruth, so many people, Irma Malasarkar and Dean Schillinger out in the West Coast. So many people I think have really rallied around this, not just one group, just to do something as basic as like, for God's sakes, can we stop doing something simple? That said, go to your pharmacy. Even if you go to CVS, you'll see the UMS is the image on the side. But I think we have not made as big of a dent on getting rid of variability. It's been state by state. Even within the states like California, we've got evidence. They actually put in a secret shopper, sent people around the state through the board of pharmacy there, and they found that the compliance was still pretty low because it didn't have teeth.
So
that's the other.
So just to play this out a little bit, because thank you for bringing us through that. I think it is an example where people can have an impact, but the implementation still needs to continue. And with UMS, there's the pharmacy side, but if the prescriber side was also organized around the UMS, it would also drive this change. Greg points out, we haven't been able to get the EHRs to kind of support this. Like
they do. Epic. I think so. We worked with Epic for a very long time, and in Wisconsin, I know there's all the Wisconsin health literacy workaround that is looking at the UMS and have been working on it. But I've been directly talking along with Ruth. We went to Epic probably about 7 years ago, if not longer ago, to start the conversation. I think the big challenge is
Well, so
just,
you said, so when you said you do, I think you
yeah.
mean it may happen, right? Because I mean, I haven't seen any epic instances with UMS yet.
So there's supposed to be, if it wasn't during COVID, I thought it was supposed to be in one. I don't know if it was in the February 2023 instance, but in our last communication with Epic, which was a while ago, that they were what made it easier for them to move it forward is that if you try to say you're going to do it for all the thousands of medications that could be prescribed, and then you start, this is what happens. The CDC came back to us and said, well, we don't think this could be used around, medications like, what about the PRN examples, for the as needed meds, or what about for taper dose medications? And I think this is where Alistair, really threw in his weight a bit more and said, look, the reality is that you'll always want a hypothetical, but where you have a carve out and it could be better and it's still a sizable chunk of medications, that shouldn't be what puts inertia in trying to get it out to the masses. And so I think when we talked to Epic, what they had been doing, and I thought it was, I know at Northwestern it is actually in our, because we've tailored it. And what we were trying to do is go to the, we've got multiple grants where we said, yeah, let's go to the source. Let's see what happens when we change and create default SIGs that reflect the UMS. So, we know about 96% of the time, physicians will use whatever is the default SIG when they're going after a medication. But it was about giving them the ability to not do it in mass, but like if they could say, okay, in this focused area where we think, yes, it's a better thing for these medications, rather than thinking about it. And that's what I think helped. Because I think a lot of the inertia was people thinking, well, it's so easy to think of a medication where I might not want to have this standardization. Again, we know what those case examples are.
Yeah. Excellent. So several questions have come across about the impact of COVID. And there's really so many things about COVID, and you're actually one of the people who jumped right in to work on COVID and health literacy. So maybe just start off by describing the COVID work that you've done in health literacy and where you see the big tie-ins.
Sure.
And did it even get as far as kind of changing the way you think about the definition of health literacy? Did it get as far as that?
Well, so our COVID work, so just as a quick background, we have something that we launched in Chicago and in New York in March of 2020. So basically, I think in February, when I'm walking out of an infectious disease meeting where we were, it was for our transplant center, and I was in on a call where we're communicating with Chinese scientists, sharing what they were learning in China about the virus, and it just became very apparent that just how serious this was going to get. So we quickly mobilized. So I think the first case had hit Washington when we started and launched a very crude survey just to get out there to kind of understand. And basically, we had a cohort made up of cohorts. We had 5 NIH large cohort studies that were all harmonized with data collection on patient-reported outcomes, health literacy, among other kind of access to full medical record and pharmacy data. And so we quickly mobilized as fast as we could, thinking that we would have a unique, and these were all people who had healthcare issues, 1 or more chronic conditions. And so it was kind of unique in that regard. And we gave ourselves 6 days because the climate was changing so fast, that we figured if we asked them a question about their knowledge about health, their knowledge about COVID, what their behaviors were they reacting to it, that it would just change because the numbers were going to skyrocket. So in March, I believe it was March 13th of 2020, we launched our cohort, and then we've done 9 waves since. We've been funded first by a National Institute of Health COVID supplement. That was a 2-year award. And then that translated into a larger full-scale R01 grant that is active, and we'll have a 6-year window capture with at least 18 months prior to COVID window. It's called the C3 study. And we've shown a lot of factors that, like, limited health literacy did kind of lead to kind of slow adoption, greater trust in the government for public health response, and and also a lag time in behavior change with regards to kind of protecting oneself from getting COVID. And we've also showed that detriment lasting, that people were slow at the beginning were more likely to get infected over the course of a year. So we published quite a lot about that, and continue to do so. If anybody's interested in learning more about the cohort, please let me know. We definitely are very open to make this a data sharing opportunity, since it does have kind of this nice longitudinal component. I think it's been less about health literacy to me, in terms of like vaccination. We had issues with health literacy and suspicion of vaccines before they were released, but that seemed to dissipate once they were out. But I'll be honest with you, I think the story that we thought was going to be more issues around health literacy and access to healthcare services, we do show that patients with limited health literacy and limited English proficiency, who've had telehealth visits more than once over the course of COVID, report having more difficulty during the interviews and more difficulty in recalling medical guidance and instructions afterwards. So that was kind of something. But the story for us with COVID is all about mental health. It's just like no surprise. I mean, it just has been that, you could argue that limited health literacy at the beginning, going into it, maybe created a greater, it could have lent itself to more social isolation, more behavioral health issues that kind of developed into it. But that's, I mean, we were surprised. So our story right now is really about almost kind of like looking at post-traumatic stress, symptoms that are appearing on patients as a result of COVID. But yeah, we continue to look at again, it's the healthcare experience, the technology experience. I still think of health literacy as a set of competencies. It's a knowledge, it's your kind of formed knowledge and worldview around health, but it's also, I think, a lot of competencies and access. And as we keep changing it, how well you can adopt and continue to follow along through your healthcare provider. I think that's been a big issue.
Well,
So yeah.
so we kind of switched one of our cohorts to a health literacy, to a COVID data collection scenario too, and we didn't have as many sites as you, just Boston and Chicago, but
you did a lot of clinical trials work though too.
Yes, I
in COVID.
I jumped into drug trials because of COVID. Well, to be fair, we had like all the staff that got sidelined and they couldn't do like their protocols. And so I was at the beginning, I don't remember if you remember, I was worried if they were going to get like furloughed, because we didn't initially know if NIH was even going to allow us to fund, to pay people for studies that were, held up because of COVID. So I thought, I don't want them to lose their jobs. So I deployed the whole team for drug trials.
I gotta tell you, I mean, so the thing that I find funny, like, I mean, there's always that issue, like the user instruction through the clinical trial process. How do you go from a controlled environment into the real world when you release things as fast as they did? So I was always curious to ask you, what's your health literacy perspective now that you were in you were leading these mega trials? Because I can tell you one thing, while I didn't learn, I don't think health literacy became like this overwhelming story for me in our COVID. I mean, it is definitely a current thing, but my own experience as a consumer and showing up in, our local Department of Public Health to get my next booster or something and trying to figure out what lane I was going into and explaining, we did a lot of COVID work outside of our cohort that was just in trying to like, not only try to just kind of provide, and this is, I attribute this more to Stacey Bailey and Sophia Weiner-Light, one of my doctoral students or doctoral PhD candidate now, but like, not only do you have to like just get the messaging right, and there is a lot of nuances to what was happening so quickly, but then the moment you finally got it right and you push it out there, you had to issue re-updates because the message has changed. And so I think that the rapidness of the communications has just been overwhelming, and to me will be something I remember quite a bit.
Yeah, I mean, there's many things, many phenomena in what you were just saying that are very powerful and important, complex aspects of the work. and of course, the fact that they changed so much may degrade the people's confidence in them and trust in all of this. I think of health literacy as I mentioned this in a previous thing as a kind of resilience factor against misinformation, disinformation, and if you will, if you want to call it something else, like understanding science literacy. Like, in fact, the truth, as best as we know it, can change and be refined and evolve over time. That's actually should reinforce, in a way, people's sense that science is evolving, and as opposed to just making us into nihilists and think that nothing's ever going to be useful. It's hard though. Yeah, go on.
Yeah, I bet if Christine Sorensen's on this, she'd be very happy to hear you say that. And Don Nutbeam, asset framed, I think that would be that's a great way to put it. Like, going into a pandemic, having, that health literacy as an asset going into it could help you at least navigate what becomes an incredibly complex information environment.
Yeah, like a resilience factor, like an asset. But the question is then, how do we grow that for people and protect it? So it's super complicated. But just because you brought up those clinical trials, we were running almost all those trials remotely, and I was super worried about, was this going to actually work for people with low health literacy to be able to do remote trials? Just to give you a sense of the potential ways for things to get messed up. For example, in several of the trials, we wanted people to do self-swabs at home and send them back to us in the mail, and that we wanted swabs each day for day 1 through 14, then again on day 21, and again on day 28.
Mm-hmm. That's crazy.
Studies as well, but just what would be your guess for what portion of those swabs came back at all, and then what portion of them came back actually correctly, like that people didn't put like a Q-tip in there instead of like the swab that comes with the media.
It's a horrible analogy, but I'm trying to think back to the data where we looked at limited health literacy and poor colonoscopy preparation.
Perfect. No, that's good. That's good. So,
what were the numbers? Well, no return at all.
So it was actually astonishingly successful, and this was not just our site. I was involved in multiple site work. 94% of the swabs came back correctly.
Whoa.
Okay, that's a tremendous amount of data, and that's people who are doing daily, and so we wanted 16 swabs from everybody, and that means that, okay, so a few things. It took a lot of support. There were a lot of phone calls. You have to be prepared for the staff to do a lot of work, but if you invest the effort, you can get fantastic results. People could do it, but it took a lot of support. But there were errors. There were people who somehow thought that, if it, like, for example, if they used the thing but the media spilled out, because these were like actual like liquid in there.
Yeah.
And if they spilled out, some people like put other liquid in there. Instead of just saying, hey, I messed this one up, can you send me a new one? Part of the whole thing is like, in healthcare in general, it would be awesome for people to be dissatisfied enough to demand that we fix things. You go to it happened so many times, like, and then we did get a few times where people like put a Q-tip, like an actual like ear Q-tip in the media thing. So it's just, but 94% came back correctly, which and at our site, where we had dominated by people with low health literacy at our site, that's actually phenomenal.
Yeah. So I see two things. I mean, with that, I'm hoping, like, glass half full, that the past 3+ years, 3.5 years, or 3.5+ years, of our all lived experience, where we've had to like learn to navigate, remote work, to reach out to patients and consumers, like that. We're putting more into the the user design and recognizing we need to have greater tech support, as you said, to make sure that if you need to help them problem solve, you need to be available for them. That even before you do that, to minimize how many calls you get back, you want to do as good of a job as possible to relay the instructions in a manner that is literacy appropriate. I mean, I feel like I'm hoping that that's the case, that there's this kind of new appreciation for everything that everybody on this call has been spending time on thinking about. Like, you know, we've been doing this for years. I see Helen Osborne in the link to, hi Helen, and thank you for your comments. And, you know, she's been doing the work for, you know, God's work for all this time. Like, you know, how do you design, make sure that people can do this in the most clear, you know, understandable, actionable way? That said, you know, I'm also concerned that, you know, I don't think we fully, I mean, especially knowing that we may continue to go forward thinking, hey, we can actually do this better. Maybe we don't need all these interviewer administered, you know, things that are more costly and slower. Maybe we can just keep doing this. I'm worried that there's a disparity in terms of who's participating that we don't even know the full extent of, because people don't feel as comfortable in these new platforms, or, you know, or they may, you know, so I feel like that may be the hidden concern, is truly understanding, like, you know, are we getting the same proportion of patients diverse by health literacy participating in our.
When we looked at that, that's actually a fantastic concern. I mean, at least during COVID, I don't know how it's going to play out, but at least during COVID, the motivation level was super high. People were really afraid, really high, and kind of captive. You know, like we're stuck at home. You know, actually, the diversity of participation went way up. So in terms of racial diversity, ethnic diversity, we also had rural participants that we would never have had if we required people to come in person, you know, in a place like Boston, you know, like, so at least I'm very bullish, but a lot of work needs to be done to make it done right and done well for remote work, remote trials of various kinds. Of course, we have to be concerned about access to these technologies, but, you know, we recently completed data collection in a rural AFib study in out of Pittsburgh, at Western Pennsylvania, and you know, fully enrolled fast. People, you know, if you build the road to it, like, it can work. Now, I was worried that study would be able to enroll, like, but it actually did work. We'll see if the
note that Michael's from Philadelphia and he calls Pittsburgh rural.
No, it was
Excuse me.
It's from the UPMC.
Ohio Valley, I get it.
It was from UPMC. It was from Pennsylvania.
Yeah.
It was from the UPMC network. But the local collaborator there for Tim Bickmore and me was Jared Magnani, who's a cardiologist at UPMC in Pittsburgh. But it's true. All of the people enrolled in the rural study were in fact rural, and you know, so at least in several of these remote studies, we've been able to get improved diversity. But let's go back to you know, several people have asked about ROI issues. Jane did, and Sabrina Kurtz-Rossi, who's also on, thank you, and has also been working in this space for quite a long time, points out, like, you know, where to apply this lens. You know, when it's with such a cross-cutting issue, maybe that's another reason why it feels like we've lost some. You used scattershot, I think, was your, like, was your Halloween reference, or I don't know, like, maybe because it's such a cross-cutting issue, it hasn't provided the same focus like if we had one disease and one institute. And you know, because basically, unless we grow as a field, unless we have many more people working here in this field, it just feels a little thin as such a cross-cutting phenomenon. Can't hear you. Can't hear you.
Can you hear me now?
Yes.
Sorry, I always have a technical glitch. It's my computer problem and lack of an IT response. But anyway, I was going to bring this up before, you know, just before thinking about NIH, is the notion, Picori, I think I want to make a shout out to them. They've lasted through the prior administration, which I think a lot of people suspected might be their end, and actually have kind of bloomed a bit. And if you look at a lot of the research that they're gearing towards, whether it's comparative effectiveness or addressing disparities or health systems, health literacy is very much prominent, and like their interest in doing research that looks at, addressing issues, like including telehealth. There was a recent one, so I feel like I want to make sure that there, we do give credit that there are definitely some wins. I think to your point earlier that we do need to pat ourselves on the back when we do have a win, and I feel like Picori is an example of where clearly it's been heard that health literacy is important. But
yeah, that's an excellent example. And just a comment, and then I'm going to shift to Helen's question on this. I thought Picori was going to be killed off. I really was initially, funded for 5 years. I thought it wasn't going to survive. I was one of the people for sure who thought it was just never going to make it. And one of the things about Picori that's just so interesting that it actually ties into exactly this issue of ROI that people have pointed out. Picori is actually not allowed to look at the financial impact of any of the stuff. Like, it's actually explicitly prohibited to not allowed to look at ROI, and that's like with financial data. And it's just amazing that that's actually maybe part of why it got protected and it allowed to flourish. So Helen's question is basically, do you think that the polarized political context will affect health literacy funding?
The polarized context of
the kind of the polarization of our, at least in the U.S., the polarization for like the funding of our government and all of that, will it affect health literacy?
Well, I think continuing resolutions affect all of us who kind of have as our bread and butter kind of NIH research or any DHHS research. I think I kind of, I think it has been always presumed that the one bipartisan thing is NIH. That's always the way we've been hearing it. That, I think that said, I would say that back in the Bush administration in the early 2000s, NIH that was when we really started to see, oh my God, like pay lines drop to like single digit numbers. HARC at one point, I think the people who preceded me, they had pay lines at HARC, like it was like 25 percentile. It was just weird. And then when we were like trying, we're, scrumming around for trying to get a 7th percentile or like a really low pay line. So that was tough. But I feel like, a lot of the perspectives I hear are more that like, I don't know if they are going to cut the budget, it seems to be kind of cross-cutting. I think Picori is an example where it was like the way it was created made it really, to your point, I agreed. I didn't think it was going to make it 5 years because of how it was funded through insurers and so forth. But I feel like, I don't know if there's I'm maybe I'm being optimistic, but I feel like if they're going to cut NIH, they're going to cut on NIH. They're not going to necessarily, they haven't sliced out, to my vision, outside of, like they haven't made specific cuts to specific programs within it. It has been shifts if they start to say we want to see more like Alzheimer's. I mean, where you have a congressional budget, and no matter as much as an institute like National Institute of Aging, there's a ton of aging issues beyond Alzheimer's, and yet that's where they've driven money. So I'm less concerned about that, more concerned about just generally them getting a budget, because we're all going to be living on last year's pay lines and conservative budgets, and things aren't going to happen. But we do need to figure out how to get more RO. There's a lot of research on caregivers. So that's a great sign, just generically to me, that psychosocial factors of health are alive and well. There's a lot of research that is framed generically around social and behavioral sciences. So I think what we need to be able to do is find a way to cultivate and drive our research and still think health literacy can be a major component, but we just have to be a bit of a shapeshifter. That's what we've done. I mean, I have a lot of else funding.
Yeah, I completely agree. I just would add also, like in IT and health IT, and AI is going to, like, there's this is going to be a space that will be invested in. It's not like going to be preferentially cut or anything. Um, so, um, so how about this other theme? I haven't actually gotten you talking about it, the life course theme, and where do you think that's going to go, and what can we do with this in health literacy?
Yeah. And I told Lucia that we'd get to the ROI issue, but I'll come back to that. But the life course thing. So just as an aside, so a lot of our work has been focused. So we've pointed this out recently. If you look at some of the most major studies that launched, I think, health literacy, and I think like the Prudential Health Literacy Study, Julie Gasmarian. If Julie's not on, she's a great shout out to Julie, our good friend, who a lot of that research was done. I mean, a lot of NIH, a lot of non-NIH studies, a lot of early stuff on health literacy that still persists today is done in older adults. And in a lot of the time, a lot of the measures, which I'd like you to speak more about, given your work with the toolshed and really spearheading all this stuff on health literacy measurement. A lot of things, a lot of what we know about health literacy really has come from older populations. And so for us, we wanted to delve more deeply into like middle age. There's a big emphasis right now on midlife, what's happening, because that's where a lot of things that go bump in the night, appropriate for Halloween today, start to happen, where health choices start to kind of become more ingrained in terms of our lifestyle, and diseases that may start to develop. But are they detected early enough? If they are detected, are you adherent to them? Other stressors. Health literacy has a really big role to play in midlife, but I don't think we really focused in on that. So a lot of our interests are thinking early on, and like what health literacy skills do people have in an earlier age time frame. And so we've created a large cohort that's being finalized now, that's funded by NIA, that looks at health literacy at middle age and how that eventually will develop into later life outcomes. And that could be a modifiable factor if we really focus on midlife. And to that end of it, I think, Marina Arvanitis, who's worked with us for years, and Shauna Yin, great colleagues, that deal with pediatrics and thinking about health literacy skills acquisition, from especially at moments where it's really formative for, the development and fostering independence, and personal responsibility around healthcare tasks away from your parents. How do those skills form? How do you have successful transitions where you become independent and doing some basic practices? That's a little bit more of a challenge, but trying to understand, how earlier aspects in the life course in the formation of health literacy really are what we're looking at right now. Like failures, maybe, I don't know if I call it failures, but maybe developmental issues around health literacy early on might be what we're looking at right now when we see all these huge disparities later in life. So I think the idea,
no, I agree with you, but it's harder to see the ROI when you're closer to. One of the things that's great about doing this with the elderly is like that's where the money's spent, and that's where these events are happening that you can count fast. And so I agree with the conversation about the ROI, but the ROI conversation will drive us away from being able to ask these longer term questions, don't you think?
Oh yeah, true. Yeah, absolutely. But I mean, I think like what we're trying to do is really just understand, what could be done at each stage of life to promote health literacy. Like, what are the objectives of health literacy, from among 10 to 12-year-olds versus, 35 to 44-year-olds. I think, and it almost kind of feels like you don't want it to be cheapened to a, Dr. Oz kind of, book, where, each decade, let's break it down. But in some ways, it's kind of like thinking about what are the public health goals, and how do we look to see if people are on target, and how do we identify, what does limited health literacy manifest? How does it manifest in different decades? I think that would be helpful rather than just, I mean, again, I run a center on aging, so I should definitely appreciate a focus on the 65 and older, and I do. I do also think that, a lot of prevention, a lot of health, how to correct maybe inadequate healthcare utilization, in midlife, things like that, I think are big targets. And it's also something NIH has shown to have an appreciation for. And I will just say a lot of health literacy issues that I differentiate from other maybe adverse health behaviors, or is limited health much of limited health literacy in our eyes, especially going back to like the medication labeling example, is it's not about motivation necessarily all the time. It's about unintentional issues. Like if you're not getting proper feedback from your healthcare team or healthcare system, or in the behavior itself, that you're doing something wrong, and it's really easy to make a mistake and not have that feedback. A lot of times I think that's what health literacy manifests as, is that people think they're doing something right because they want the benefit of treatment, and then they make an error, and without having ever kind of peeled back the curtain to really understand what people are doing and how they're doing it. That's probably the value that we found the most with our studies, is we started to actually have people objectively demonstrate, what are you doing? How do you do the tasks that we're already asking you to do, and see where the errors are? Because a lot of times it's obviously because it's us. The word I always hate, the term I hate that the CDC uses a lot to understand that it might be a patient error, is therapeutic misadventure. As if that's like this, I don't know if that's the right term. It just, something doesn't sit.
So,
hey, question for you though. I mean, now that to bring it up again, but do you think it is acceptable that we have so many diverse ways of measuring what hopefully is the same thing? Do you think it's the same thing? Because that could be a course correction for the field, I think, because it also, from someone on the outside looking in, might going, I still don't know what this is, or they may have this superficial definition that they put forward to it. So I'm curious, having spent all the time in the NLM tool shed, looking in the tool shed, what did you find?
Excellent. Well, because it's Halloween, I think I should say, sometimes it's more like a shrieking Shrek. It's not so much a tool shed sometimes as a shrieking shack. Okay. Sorry, I just had to throw that out there. So in many ways, when you look across the measures and then the projects that are done, it would be reasonable to say, is this one field anyway?
Yep.
So there are people who do interventions that don't call themselves health literacy interventions, that I think they actually have things for us to learn from, that in fact they're doing interventions that are affecting things that I call health literacy. And then there are people who do interventions that call them health literacy that I'm like, what? Is that even health literacy? So I think it's appropriate to come to these conversations with equal opportunity skepticism. And the same is true about the tools. I try my best to only include tools in the tool shed that actually are related to this concept, but there's reason to worry. I mean, it's very easy to start mixing results from studies that are based on tools that are measuring in such different ways that it really could not be the same thing. So I just want to point out, I want to do a shout out across. It's Halloween, so I have the power to do it, to Jürgen. Jürgen Pelikan, who's deceased, who was also another very important, very influential person in the field. If you don't know Jürgen's work, I recommend reading Jürgen's work. Jürgen was really one of the drivers for European countrywide measures, and also in other in Asia too. And Jürgen, was a sociologist, and his perspective about these measurement programs, which were self-report programs, self-reported measures of health literacy, was that at the sociological level, at the societal level, over time, that we could determine if there was an improving or worsening match between the needs and the system. And over time, that sociologically we could make such judgments. And that's such a different project than, you know, when you're doing most of your work, most of your work is in health services. Like, and so the project that you're undertaking is not so much at the sociological level, at the societal level. When you're doing an intervention like in a clinical context, it's a really different project, and the undertaking is different. The needs and purpose of the measurement is different, and I think all this has to kind of be kept in mind. And so maybe this goes back to some of the questions that people were asking before. Greg mentioned, like, if we should have an organization. You know, effectively, I've felt that the field needs a big tent as opposed to like a czar or a pope. You know, if we had an overlord of health literacy that says, this is the definition, stop making new ones. This is the measure, stop making new ones. Like, you know, but we're not in that spot.
You know, the analogy that you might like is, to me, like, do you want to be going to Comic-Con or a Star Trek? I mean, do you go big, or do you at least have some semblance where I can recognize everybody walking around? I mean, honestly, your point about, I do think, like, you know, Jürgen's work about, you know, Jürgen's, the idea that, yeah, there is value in knowing, in some ways, is the health system I'm experiencing now in this decade meeting my needs, versus, but to your point,
I'm not against Jürgen's effort. I'm not against any of it. I'm just saying it's so different than, like, if I'm doing an intervention about, you know, this clinic of patients with asthma. It's just a very different.
Yeah. Well, you know, I mean, like, a lot of issues in the aging world right now, and again, I'm doing a lot of work, you know, in geriatrics research specifically, and you know, there's a lot of, I mean, I do a lot of my work in objective measures. I tend to prefer objective assessments because I do think it's getting at something that I'm more familiar with.
Just to defend Jürgen for a moment, because he's not here to defend himself. He never liked when I called my measures objective measures and his measures subjective measures.
I know you pitted me against Jürgen in one of the previous HARCs.
It's true. We had a discussion. You called it a debate, a discussion between the two of you, and he felt it was, maybe I wasn't a fair moderator because I called his measures subjective and your measures objective. What he preferred, since he's not here to defend himself, he preferred to say that the measures that you and I tend to like are test-based measures as opposed to objective, and that the measures that he was doing were self-report measures.
Yes.
Yeah. Anyway, fair enough. Go on.
We do see a lot of, what's been, you know, in aging research. So if you do I'll say test-based assessment of physical function, like a 6-minute walk or an SPPV, it doesn't always correlate, and usually doesn't correlate well with self-report through like a promise measure, and that goes across a lot of test-based measures for other, you know, things beyond health literacy. So I think it is, but and there is value in both. But you're right, like when you're in a, you know, what measure you put into that clinical study may lead you to a much different, you know, hypothesis or outcome, or, you know, finding, and that's why I think it has been somewhat problematic, in my mind at least, that we have a big tent currently, and that's fine, but we do need some harmonization, and the lack of harmonization on what we're measuring, to me, is probably also causing some confusion on the outside for people who don't do day-to-day health literacy research, but just want health literacy as a covariate in the bigger model and bigger picture, and they get confused. Like going into the toolbox, I don't know if you have people, the tool shed, I'm sorry. There's so many measures.
I completely agree. I mean, there's, like, you know, we're gonna have 300 measures before by the end of the year, pretty much. We have a whole the lineup of measures to still bring in. But, you know, I do agree that this lends to confusion, but I'm not sure what the path out of it is. There's a ton of, like, derivative problems from this, and there are contexts that do sound like they would benefit from like a special tool, and then there's contexts where I'm like, really, do we need another tool just for this really small slice? And this, it gets to be a real big mess. So like, it'd be awesome if we had a unified thing. The example that I would give even stronger than like the one that you gave is sleep.
Mm-hmm.
Objective measures of sleep are extremely discordant from subjective measures of sleep. And there's just many examples like this. And the thing is, like in projects where we've measured concurrently test-based measures and self-report measures, the correlations can be weak. And it depends on the study in particular. So I think this is one of those things where, like, I'm not sure what the answer is, but we have to proceed with caution. But even if we would just get the test-based measures together and created, like I think I told you, I wanted to create a greenhouse.
Yeah.
I think we could do it. I think if we could get NIH to share some money with us for it, we could bring all the test-based measures together and create build effectively like the PROMIS, health literacy measure effective, conceptually. That I think that could be done. It would be a project. We need to collect new data, make sure it's generalizable, make sure the items aren't being biased in various ways.
Yeah, I mean, one thing I know I've talked to some colleagues about, I mean, like, and this to me just is actually probably, I mean, I think some people are thinking, do I need to include multiple measures of health literacy? And, I get worried. I mean, I actually quite agree that, that'll give you more precision, but I also worry that for people who are not like total health literacy wonks, then you're saying, what? I just want something brief, and you want me to know how to do like these three, that it's gonna stifle, health literacy research growth. But that also, I think, like, I don't know if you offer in the tool shed a best of breed, these are measures that have the most validation, or using those diverse samples of research to date that we recommend, and same thing for test-based or self-report.
So I've avoided this. I've had different times people say, Michael, I want you to be the Pope of this shed, you bless this one or don't bless that one, so I've been avoiding that. And but if there was a national organization, or if there was some other kind of thing, there's been calls in the chat for accreditation bodies to make recommendations. And if you could even imagine, like, saying, okay, you're going to collect social determinants of health, also collect health literacy, and this is how we want you to do it. And I don't know if there's tools that are actually proven their worth that way. And
well, I mean, so a lot of my research deals with cognitive aging, and so I deal a lot with cognitive measures of cognitive function, and those measures do, they're not always accredited, and most of them are, but the notion that test-based measures, since you're not letting me use objective, but I mean, I think some of these measures require, updates.
Oh, absolutely.
Of learning, and also and quite honestly, with health literacy, it's even different, because you're trying to oftentimes assess something that is, it's an example, a reflection of the current measure of the current health literacy climate. Yeah.
Absolutely. I would say that many of the tools that are in the shed and that are validated at this point, are out of date, in the sense that none of them happened at a time when EHRs where patient portals were available to everybody. You would not make a test like at this point that didn't include those skills. So there's just so many aspects of the current care environment and information landscape that weren't contemplated when the measures were developed. So even just the idea of discerning misinformation or being able to interact with the portal, these are skills that are normal skills now that everyone kind of needs to contemplate, and there are no items about them in any of those tools. So because they were developed just a couple of years ago, when those skill sets weren't even on the table. Okay. Mm-hmm. With that, Mike, it's been great to talk with you about these things.
Time to hand out candy at the door.
Yes, you got to get ready for the public health intervention that you're about to do, giving kids candy.
That's true.
Yeah. So thank you, everybody. We have a half an hour break right now that it'd be great if people would check out the posters. Because it's a virtual meeting, I worry that the posters will not get the attention they deserve. Some of the posters have with them, if you click on the link, you can see a video that goes along with the posters. The posters have their own tab at the top of the page on the homepage for the conference. If you're having trouble finding it, let somebody know. Check out the posters, email the authors. They'd be excited to know that you're paying, that you have your whatever questions you have. And then we have another session starting on the half hour. So thanks, Mike. Be well, everybody.
Great. Take care.